Welcome to the deep dive. We've got this stack of material you sent over, articles, notes, all zeroing in on a really vital topic, managing these critical life-threatening infections, especially when they lead to shock.
That's right. We're going to look into, how the body handles emergencies, where things can go wrong, how we try to step in with medications, and importantly, some real debates and different takes on the best way to actually manage these patients.
Okay, so our goal here is to wade through this, pull out the really key stuff, the essential insights, maybe some surprising bits, basically help you get a good, solid understanding quickly. It's your deep dive.
Yeah, as the sources make clear, it's definitely not always black and white. There are conflicting ideas sometimes, real complexity. We'll try to navigate that.
Great. So let's rewind a bit. Before everything goes sideways, how does the body normally keep things like blood pressure and stress under control?
Well, a really central part of that, based on this material, is the adrenal glands. They make hormones like cortisol and aldosterone, super important for blood pressure, stress response, all that.
And the sources really stress that these two hormones, cortisol and aldosterone, they're actually controlled by different pathways. That seems key.
It really is. So cortisol, that's run by the HPA axis. Think of it like a chain of command. Brain hypothalamus signals the pituitary, which then signals the adrenals.
A feedback loop, right?
Exactly. But aldosterone, that's mostly driven by something different, the RAAS system. That starts in the kidneys with renin release. Totally separate pathway.
Oh, okay. So if the adrenal glands themselves are damaged, that's one type of adrenal insufficiency AI.
Right, primary air.
But if the problem's upstream, like in the brain signaling,
Yeah,
that's different because of those separate controls.
precisely. With primary AI gland damage, you're likely short on both cortisol and aldosterone.
Makes sense.
But if it's the HPA axis, the signaling that's secondary or tertiary AI, then cortisol is the problem. But RAAS is usually humming along fine, so aldosterone might be okay.
And that explains why patients on chronic steroids need extra cover during illness or surgery, right? The sources mentioned that suppresses their HPA axis.
Yeah, it's like a temporary secondary AI. They need those stress doses, the 3x3 rule concept or specific surgical doses the material touches on.
It's a direct result of understanding that suppressed feedback loop.
It's a very practical point.
So now let's get into when things really escalate. Sepsis and septic shock. The sources define these, but also note the definitions have kind of shifted.
Yeah, they talk about the move from sepsis stesum, basically. Low blood pressure despite getting fluids, to the newer sepsis septa definition.
Which requires what again?
Sepsis the third, you need vasopressors, those pressure support meds, just to keep the mean arterial pressure, the MAP, above 65. And you need a high lactate level, over 2.
But, and this seems important, the material warns that neither definition is, perfect for managing an individual patient at the bedside. More for research.
Yeah, they're useful labels, but bedside care is more nuanced. So what's physically happening in septic shock?
Right.
Well, you've got an infection setting off this massive uncontrolled inflammation. It makes blood vessels dilate everywhere, get really leaky.
Floppy vessels.
Exactly. Blood flow gets totally messed up, goes to the wrong places, and sometimes the heart muscle itself can get stunned, doesn't pump as well.
And you can't treat it effectively if you don't know what's causing it. The sources hammer home finding the source of that infection.
Quickly.
Absolutely. They list the usual suspects: meningitis, pneumonia, IV line infections, abdominal problems like a perforation, kidney infections, nasty skin infections.
Gotta find it.
And getting the right tests fast is part of that. Labs like lactate, procalcitonin, maybe an NLR count.
What's NLR again?
Neutrophil to lymphocyte ratio, just another inflammatory marker. Plus cultures, blood, urine, wherever you suspect, and imaging, chest x-ray, CT scans. Okay, but what if it looks like septic shock, but isn't? The material talks about sepsis mimics.
Yeah, this is crucial. Not everything that drops the blood pressure and looks sick is actually sepsis. Could be an adrenal crisis, tying back to our earlier point.
Right.
Or thyroid storm, severe DKA, maybe a clot blocking blood flow to the gut, even a bad allergic reaction, anaphylaxis.
So if the picture's fuzzy, or maybe procalcitonin is surprisingly low.
You got to think about these mimics because, treating thyroid storm like it's bacterial sepsis isn't going to work very well.
And one point the sources are really direct about: source control, getting rid of the infection source.
Yeah, they basically say, failing to do that, drain the abscess, remove the infected line, fix the hole in the bowel is a major reason people die. All the support might fail if the source is still there.
Can't bail out a sinking ship without plugging the hole.
Exactly. Critical point.
So when the blood pressure is failing, we reach for vasopressors. The material you shared breaks these down really nicely.
Yeah, they work by tapping into the sympathetic nervous system, your fight or flight response. They hit specific receptors to get effects that support pressure and flow.
I like the analogy in the source getting punched by Mike Tyson to explain the receptor effects.
Right, makes it stick. So alpha-1 receptors, they mostly cause vasoconstriction, tighten the pipes, raise the pressure.
Okay.
Beta-1, that speeds up the heart and makes it squeeze harder, boosts output.
Got it.
Beta-2 is a bit different, helps airways open, but also some vasodilation in places like muscles. Then you have dopamine receptors, vasopressin receptors, V1 for constriction, V2 for water retention.
Different tools for different jobs. Let's run through the main players. Norepinephrine.
Yep, norepinephrine. Usually the first one you grab for most shock types, definitely for septic shock. It's mainly alpha-1, so good vasoconstriction, with a decent amount of beta-1 to help the heart, too.
Dosed in mics per minute, titratable, but less effective if the patient's very acidic.
Correct. That's a key point, and usually less likely to cause really fast heart rhythms compared to, say, epinephrine.
Speaking of which, epinephrine.
Epi. This one hits alpha-1, beta-1, and beta-2 pretty hard, more balanced agonist. You see it used in different shocks, sometimes added on in septic shock if NOR-BP isn't enough.
Also, mics per minute, fast titration, but risks.
Yeah, the strong beta effects mean a higher risk of tachyarrhythmias, those fast, irregular heartbeats. And because it clamps down peripherally, more risk of tissue damage, like fingers and toes, especially if it leaks out of the vein.
Okay. What about phenylephrine, the pure alpha-1?
Yeah, highly selective. So its niche is maybe when you need pressure support, but the patient's heart rate is already really high. You don't want that extra beta-1 kick.
Makes sense.
Dosing is often higher, mics per minute still. Works instantly, but lasts a bit longer, maybe 15-30 minutes. Can cause a reflex slowing of the heart, though, and people can get tolerant to it.
Right. Vasopressin. Different mechanism, different use. Often an add-on.
Exactly. Usually added when norepi doses are getting high and you're still not at your MAP goal. It hits V1 and V2 receptors, vasoconstriction, water retention.
And the dosing and titration are different here.
Big time. It's dosed in units per minute, much smaller numbers, like 0.01 to 0.04, and you cannot titrate it quickly. Takes 15-20 minutes to fully work, lasts maybe 30-60 minutes. Set it and forget it, almost.
What are the pros and cons noted?
Pros. It works well even if the patient is acidotic and might have some kidney benefits. Cons. It can actually reduce cardiac output, so maybe avoid if the heart's already weak. And it's a potent vasoconstrictor, so risk of cutting off flow to digits, especially with no repi on board. Peripheral infusion is generally a bad idea.
Good to know. Lastly, dopamine. Positioned as kind of a last resort.
Pretty much. It's complicated because what it does changes with the dose. Low dose for dopamine receptors, medium dose more beta-1, high dose more alpha-1.
And dose differently too.
Yeah, mcg per kilogram per minute, like norepi, doesn't work as well in acidosis. Risks are tachyarrhythmias, can worsen lung congestion, and tissue damage peripherally. And just to be clear, this isn't the dopamine used for Parkinson's. IV dopamine doesn't get into the brain.
Right, important distinction. And just quickly, peripheral versus central lines for these.
Central lines are definitely preferred, safer long-term. Peripheral is sometimes necessary initially, but you have to watch closely for infiltration, especially with drugs like vasopressin or high-dose epinephrine. It's a risk-benefit goal.
Okay, so we've supported the pressure. What else is critical? Fluids come up a lot and seem controversial based on these sources.
Yeah, this is a big one. The material really pushes back on the idea of just flooding patients with liters and liters of fluid. They argue there's actually little top-tier evidence that huge volumes help.
And that fluids can't fix the core issue.
Right, they can't fix the leaky dilated vessels or the bad blood distribution, and they argue too much fluid can actually be harmful, damaging that delicate inner lining of blood vessels, the glycocalyx.
So what's the suggested approach? More moderate initial fluids, maybe a liter or two for most. Unless they're clearly dehydrated or losing fluid, then stop, unless there are ongoing losses. And really try to avoid getting massively fluid like maybe keep the total net gain under 5 liters or so if possible.
And things like checking the CVP or IVC size aren't reliable guides for giving more fluid.
The sources strongly suggest they're poor predictors of fluid responsiveness. You might fill the tank, but it doesn't mean the engine works better.
That's a really key takeaway, challenging that, but more fluid is always a better idea. Okay, how about steroids? Stress dose hydrocortisone.
Yep, commonly used. Usually around 200 milligrams of hydrocortisone a day. The evidence, as summarized here, seems to show it helps get people off vasopressors faster, off the ventilator sooner, and out of the ICU quicker.
But the direct survival benefit is still debated.
That seems to be the consensus from the broader literature reflected here. Those other benefits seem pretty consistent, though. And importantly, the risk of causing a new infection at these doses seems pretty low, contrary to maybe older concerns. And how it's given matters. Intermittent doses better than a continuous drip.
They suggest maybe 50 milligram IV every 6 hours might be preferable. Ensures good levels quickly, maybe easier logistically than a continuous infusion. And they also mention adding fludrocortisone, another steroid, probably isn't necessary. Hydrocortisone has enough of that mineralocorticoid effect, and big trials didn't show an added benefit.
But absolutely crucial for patients with known AI or on chronic steroids already.
Oh yeah, non-negotiable for them. Got to give those stress doses. And finally, DVT prophylaxis blood clot prevention.
Standard care in critical illness, right?
Heparin. Yes, high risk and septic shock. Heparin is recommended. And interestingly, the material mentions some research suggesting heparin might also help protect that glycocalyx lining we talked about, another potential benefit.
Okay, fascinating. Now let's dig into the really tricky areas highlighted in the sources, the uncertainty zones. Antibiotic timing, for one.
Right. The mantra is hit hard, early, and appropriately. Makes intuitive sense, kill the bugs fast. But the sources stress the evidence specifically for the early part, the timing, is actually quite controversial.
How so?
Proving definitively with a randomized trial that giving antibiotics at hour 1 versus hour 3 causes better survival is incredibly hard to do ethically. You can't really randomize sick people to delayed treatment.
Which leads to this major point from the sources, the fallacy of timed intervention studies. This really stood out.
It's a crucial concept. They argue that studies showing patients survive better if they get treatment X by time Y. Well, that's often just a correlation. It doesn't prove the timing itself caused the better outcome.
Why not? What are the confounders?
Loads of them. Maybe the sickest patients get seen first and get antibiotics fastest, but they still do worse because they were sicker to begin with.
Okay.
Or maybe getting antibiotics quickly is just a sign you're in a really good hospital that does everything well and aggressively. It's the whole package of care, not just the antibiotic timing.
Or even just staffing levels, day shift versus night shift.
Exactly. The sources mention the famous very early Kumar study on sepsis antibiotics. It showed this huge, almost biologically implausible survival benefit per hour of delay. They argue that points more to these strong confounders than pure cause and effect.
And the pneumonia example, the 4-hour rule.
Right, a historical push to get antibiotics in within 4 hours for pneumonia. Sounded good, but it led to doctors giving antibiotics too quickly, sometimes misdiagnosing other things as pneumonia just to meet the metric. It caused harm, and the rule was eventually dropped when better studies controlled for those confounders.
So the takeaway is, speed is good, but accuracy is paramount. Rushing without being sure can be harmful. The ideal time is probably complex and hard to pin down with trials.
That's the essence of it, which brings us to resuscitative endpoints, the targets we aim for. If timing studies are tricky, what about our targets like MAP?
Yeah, how solid is the evidence for aiming for a specific number?
Again, the sources urge caution. We use these targets, MAP, urine output, etc., to guide our adjustments, turn pressors up or down. But the evidence that hitting, say, a MAP of exactly 65 causes a better outcome isn't that strong.
It's more that patients who are getting better tend to have a MAP of 65. Correlation again.
Often, yes. They're probably best used as signposts, guides for titration, or maybe triggers to stop and rethink everything if you're way off target. They're tools, not magic bullets.
Okay, let's look at the specifics. MAP mean arterial pressure. Standard target 65.
Usually, yeah. That's the conventional goal for perfusing organs. But the sources say maybe aim higher, like 80, 85 in some cases.
Okay.
Patients with chronic high blood pressure normally, or maybe specific issues like cirrhosis where higher pressure might help kidney function. You could even do a vasopressor challenge, bump the pressor, see if things like urine output improve at a higher MAP.
And conversely, maybe aim a bit lower sometimes.
Yeah, perhaps 60 could be okay for someone who normally runs low blood pressure, or maybe someone on dialysis who tolerates lower pressures. It's about individualizing.
Heart rate, tachycardia is expected, right?
It's the body trying to compensate, a normal stress response. The sources say manage the extremes. If it's way too slow and cardiac output seems low, maybe an epi challenge could help.
And if it's excessively fast, like over 140.
And seems to be causing problems, maybe consider switching to a pressor with less beta stimulation, like phenylephrine, or adding vasopressin might help slow it down.
Urine output. Usual goal, 0.3, 0.5 millirel QARH.
That's typical.
Got it.
But the key point here is that low urine output is nonspecific. It might mean not enough perfusion, but it could also just mean the kidneys are injured directly.
So giving more fluids or cranking up pressors won't help if it's intrinsic kidney injury.
Exactly. You can't force urine out of a damaged kidney just by pushing hemodynamics harder.
Fluid balance comes up again here too. Still aiming to avoid big positive balances.
Yes, reinforces that earlier point. Significant net positive fluid balance, maybe over 5 liters or so, seems correlated with worse outcomes, higher mortality.
A consistent message, okay? Lactate. This is a big one.
Huge. But the perspective in these sources is really interesting. They argue lactate and septic shock often isn't just about tissues lacking oxygen.
What is it then?
It's often more like an index of the body's own stress response specifically, how much epinephrine the body is producing internally, stress hormone activity.
Wow. Okay, so a rising lactate isn't always bad.
Well, very high levels, like over 10, are generally bad news regardless. But a moderately rising lactate, if the patient also seems to have a strong epinephrine surge going on, like being tachycardic, maybe warm, might just reflect that stress response working. It's not necessarily something you aggressively treat.
But if lactate is rising without that epinephrine picture,
That's different. That should make you hunt harder for missed injury, ongoing tissue damage, maybe the wrong diagnosis altogether. Just chasing the lactate number down without knowing why it's high isn't really evidence-based, according to these sources.
that really reframes how you interpret lactate. Fascinating. What about just looking at the patient? Skin perfusion.
Yes. Basic clinical exam stuff. Modeling that patchy, purplish skin suggesting poor flow. Capillary refill time, press the nail bed or skin, see how fast color returns. Should be under 3 to 4 seconds.
Longer means sluggish flow.
Right, 5 seconds is definitely delayed. And just skin temperature warm versus cold hands and feet. These are really useful.
How do they guide treatment?
Well, if the fingers and toes are getting cold and mottled on vasopressin, maybe you need to back down on that specific drug.
Yes,
If the patient is generally cold, maybe their heart pump function is poor, cold shock, and they need more inotropic support like adding epinephrine or dobutamine.
And if skin perfusion looks good,
That might be a sign that pushing resuscitation much harder isn't necessary and could even be harmful. It's a good clinical endpoint.
and the sources also suggest avoiding some more complex measurements, like CVP.
Yeah, central venous pressure and also mixed venous oxygen saturation, SVO2. They argue the complexity of measurement and interpretation and lack of proven benefit from targeting them makes them less useful than these simpler clinical signs or basic hemodynamics. Stick to what's reliable and clinically relevant.
Got it. And they briefly touched on septic cardiomyopathy.
Right. The fact that sepsis can directly weaken the heart muscle itself makes things more complicated, might require specific heart support like dobutamine, or maybe even rescue therapies like methylene blue or calcium in specific situations, adds another layer.
Okay, wow. That was a really comprehensive deep dive through this material. It's clear that managing septic shock is, well, it's incredibly complex.
Yeah, it's definitely not a simple algorithm. It's this constant balancing act, supporting the pressure, finding and fixing the infection source, being really thoughtful about fluids, using extras like steroids when they fit.
All while keeping a close eye on how the individual patient is responding and, like the source is really stressed, critically thinking about the evidence behind our actions.
Exactly. Those time metrics, the specific targets, they're useful guides, but they can oversimplify things if you don't appreciate the confounders and the nuances.
Accuracy in diagnosis, thoughtful management, tailoring it. That seems key.
Paramount.
So wrapping this up, considering all this complexity, the conflicting data sometimes, the limits of our metrics, the sources kind of leave us with this provocative thought, don't they? How do we best square guidelines, which come from big studies, with the need to treat the unique person in front of us? And when we say hit hard, early, and appropriately, what does appropriately really mean in practice, given everything we've discussed?
Definitely something to keep mulling over as you encounter these challenging situations.